More of the same won't fix general practice. That was the conclusion of a King's Fund analysis of the current state of general practice. So what will? My new book, Medical Generalism Now, describes why, and most importantly how, advanced generalist medicine must be part of the solution. In these short videos, I'm going to introduce some of the hot topics that I cover in the book, starting with the hottest of them all, the question of access. Newspaper headlines are currently plastered with stories about failure of access in the NHS. Growing waiting times, lack of beds, people spending hours waiting on phone lines. Yet, at the same time, we also know that English general practice is offering more than 30 million appointments a month. More than half of the population of our affluent Western nation needing access to formal medical health care every month. What's happening? In Western societies, formal healthcare is a key component we use to maintain health. But it is, or should be, a relatively minor one. For all the healthcare professionals listening to this, do you remember the rainbow diagram from Dahlgren and Whitehead showing the determinants of health? Their diagram highlights how healthcare is just one small part in a much wider range of social factors that shape health. Yet as a nation, we seem to have forgotten this and to be consistently expanding the role of medicine. Well, that's because we have an ageing population living with multiple long-term conditions, I hear you reply. But actually, a report from the Office of Budgetary Responsibility in 2020 challenges that assumption. A health economics look at the reasons behind the rising demand on healthcare in the UK showed that whilst 9% of the rise is explained by demographics, ageing populations, 62% is explained by the intensity and volume of healthcare. They repeated that same analysis in countries around the globe, and they saw a similar pattern in places like the US. But in other European countries like Germany and France, the drivers are different, with much greater effect there coming from both demographics and economic factors like inflation. In other words, it is our healthcare system, the way we design and run healthcare, that's driving the growing demand and pressure on access. And if our efforts to both pull and push ever more people into healthcare was delivering universal good, then that would be fine. But we know it's not. We see evidence of growing iatrogenic harm from healthcare. Not just healthcare mistakes or the side effects of treatment, but the effects of overdiagnosis, treatment burden, problematic polypharmacy. Yet we continue to respond to those by trying to do more of the same, increasing the availability of current healthcare, but perhaps in doing so, reducing access to the model of healthcare that we know delivers efficient, effective, equitable healthcare. The model of healthcare that is whole person-centred primary healthcare. Availability refers to things like the number of appointments we have, the waiting time to be seen. Access is much more complex. Paradoxically, our understanding of access comes from research into why underserved groups can't access healthcare. That work highlights 3 key elements that are necessary to optimise access to healthcare. Firstly, a person must be able to recognise themselves as eligible for healthcare, as being able to benefit. An idea we call candidacy. Secondly, there must be a match between the ill person and healthcare to enable both to be actively involved in addressing the problem. That's concordance. And thirdly, The experience of healthcare should ideally leave the person better able to deal with similar health issues themselves in the future. The concept of recursivity. In our efforts to improve availability, with more appointments, reduced waiting times, have we failed to pay sufficient attention to these three core elements of access? So what can we do instead? In medical generalism now, I propose the answer lies in an unexpected direction. There has been a suggestion that if we want to improve access, then we need to remove the traditional GP gatekeeper role. The aim being to improve the flow from primary to secondary care health settings and remove bottlenecks. It's a suggestion that tackles availability, but not access. My proposal is that instead we need to both revise and strengthen an advanced generalist gatekeeper role to address both access problems as well as the iatrogenic harm of too much medicine. So my proposal draws on the seminal work from Iona Heath, former president of the Royal College of GPs and a leading thinker in modern UK general practice. In her 2011 Harveian lecture, she challenged the commonly held view of the GP gatekeeper role as simply managing the referral gate into hospital care. It's certainly a job we ask GPs to do, but as Iona Heath described, it's a misunderstanding of the work that GPs do. GPs as consultants in general practice medicine who actually manage a completely different gate. Instead, they are the guardians of the gate between a medicalised and non-medicalised understanding of illness. So our patients come to see us when they're ill, when something is interfering with their everyday life, and they think that the problem is something to do with their health. A specialist medical approach asks, could I medically treat this person? Do they have a disease and is it safe to treat? Often that's the start of a chain of tests and even referrals. Advanced Generalist Medicine asks a different question. Should I medicalise this problem? What are the options, benefits and risks of managing this medically or non-medically, of not starting or at least significantly curtailing the string of tests and referrals? What are the implications for candidacy, concordance, and recursivity? Take the example of someone who comes to see you because they're having problems with their sleep. If our sole focus is on making or excluding a diagnosis, we're likely to start with a whole series of tests, which in themselves often prompt more tests and so on. Perhaps we have a trial of medical treatment. By now, our patient understandably thinks they have a medical problem and so need medical treatment, but they're starting to think GP care isn't good enough. So they think they need access to specialist care. And if that referral doesn't then solve the problem, they feel they need further onward referral. And we start to see how our healthcare system has created the problems I described at the outset of this talk. The advanced generalist clinician working at Heath's Generalist Gate will also be considering all the non-medical factors which may contribute to the sleep problems. They'll actively explore both medical and non-medical explanations and management options with the patient. In doing so, shaping their understanding of what is happening and how both partners can work together to find a way forward. Advanced Generalist Medicine pays attention to all three elements of access: the individual's understanding of their capacity to benefit from healthcare, their role in managing the health problems, and enabling them to better manage problems that arise in the future. In medical generalism now, I discuss how practically we do that in everyday practice in much more detail. I also discuss some examples of how we're helping frontline practitioners use these ideas in their daily practice. But I also recognise that if we want to use advanced generalist medicine to change the direction of travel described by that Office of Budgetary Responsibility report, then we'll need to make changes in both how we train health professionals and design practices. And I'm going to discuss both of those in my next videos. But I finish this one with a note of optimism and a creative challenge. Namely, that if we want to strengthen the Advanced Generalist Gatekeeper role, we can improve healthcare access and reclaim general practice.